Pediatric trauma, supracondylar humeral fractures. Epidemiology. Supracondylar humeral fractures are the most common pediatric fractures, typically occurring in children aged 5 to 8 years, with a decrease in frequency after 9 years. Anatomy. Bone remodeling is more prominent in children aged 5 to 8 years. The supracondylar region has a wider AP diameter, making it prone to fractures. Ligamentous laxity and hyperextension injuries are common due to a thicker anterior capsule and a weaker posterior capsule. Ossific centers in the elbow appear at epicondyles, capitellum, radial head, medial epicondyle, olecranon, and lateral epicondyle by around 10 to 12 years. Mechanism of injury. Extension-type fractures typically occur from a fall onto an outstretched hand with or without valgus, varus forces. Flexion-type fractures result from a fall onto a flexed elbow. Clinical presentation. Preserved equilateral triangle between the olecranon, medial, and lateral epicondyles. Pucker sign. Dimples in the skin anteriorly due to the proximal fragment penetrating the brachialis muscle. This alerts the examiner that reduction may be difficult with simple manipulation. Neurological assessment. Nerves, radial, median, ulnar. Vascular, radial pulse, with re-examination after splinting to assess perfusion. Imaging. AP view. Bauman's angle. Normal range is 15 degrees to 20 degrees, measured between the line along the growth plate of the lateral condyle and the line perpendicular to the long axis of the humerus. Metaphyseal diaphyseal angle. Normal range 100 degrees. Lateral view. Teardrop sign, formed by the posterior margin of the coronoid fossa, anterior margin of the olecranon fossa, and the superior margin of the capitellar ossifying center. Anterior humeral line should intersect the middle third of the capitellar ossification center when the elbow is extended distally. Coronoid line, tangent to the anterior aspect of the lateral condyle from the anterior border of the coronoid process. Comparison films use the contralateral elbow for comparison. Internal and external rotation views used if fractures are not clearly demonstrated. Fat pad sign. The anterior, posterior, and supinator fat pads can indicate intra-articular effusion and displacement. The anterior fat pad is sensitive to minimal effusion, although it has low specificity. Classification. Gartland's classification for supracondylar humeral fractures. Type 1. Non-displaced fractures. Type 2. Displaced fractures with an intact anterior cortex. Type 3. Complete displacement, which can be anterolateral, posterolateral, posteromedial. Treatment. Conservative. Above elbow cast or splint with the elbow at 90 degrees and the forearm in a neutral position for about 1 month. Closed reduction and percutaneous pinning, CRPP. Traction. To disengage the proximal fragment from the brachialis. Flexion of the elbow. To help push the distal fragment forward. Forearm positioning. Pronation for posteromedial displacement. Supination for posterolateral displacement. Pinning. 2 lateral pins or crossed pins. The latter increases stability but also the risk of ulnar nerve injury. Pins are typically removed after 1 month. Open reduction and pinning, OR plus pinning. Indicated in open fractures, neurovascular injuries, irreducible fractures, non-union or malunion. Complications. Nerve injuries. Median, radial, and ulnar nerve injuries, more common in flexion-type fractures and associated with valgus deformity. Vascular injury. Occurs in 5 to 12% of cases, with concerns about distal limb perfusion after crossing. If capillary perfusion is inadequate or no pulse is felt, even with Doppler, reappraisal of fracture position or surgical exploration may be needed. Deformity. Varus deformity is more common than valgus. Loss of motion, LOM, and joint stiffness can occur. Myositis ossificans can develop after vigorous manipulation during reduction. Compartment syndrome. Rare but can be exacerbated by elbow hyperflexion and excessive swelling in the cubital fossa.